I'm the chief. I'm the, I know, one quick sec. Sorry about that. There is some construction going on outside our offices. Apologize. I'm Dr. Sailaja Musunuri. I'm the Chief of Psychiatry and EVP of Integrative Medicine at Woods System of Care. Before I start, I just want to take a couple of minutes. This is kind of like a really what we are thinking about for the next phase in our Wood system of care, developing an interventional psychiatry, the next approach to look at some treatment resistant cases. So there is a lot of technical information in this presentation. And I on purpose tried to make it less scientific and make it more applicable to everyone so that we can set up in the outpatient practice. And if you can turn your camera on so that I can see your beautiful faces, that'll be good. Otherwise, I'll be talking to the wall. The other thing, I just want to take a minute to thank Charlotte Layton, who really helped me out with the slides. She's awesome. Charlotte, I know you are there. Thank you. All these slides are really brand new because this is all, the information is all new. So pay close attention to certain details. I'm sure you guys have a lot of questions and we can take them at the end or put it in the chart once once we are going through certain things and the different modalities. And I appreciate all the feedback. As like I said, as we are moving in that direction, we all need to collectively think about what are our next steps. So what is interventional psychiatry? It's kind of like a new branch or subspecialty within psychiatry where we use different modalities like neurostimulation technologies or medication. There is one medication that I'll be discussing about to treat mental health disorders. There has been these paradigms from the beginning. The biggest one is, we think about from the pharmacotherapy standpoint. We thought for several decades now that there is a problem with the neurotransmitters in the brain. For example, depression, low serotonin, dopamine excess can cause psychosis. We were focusing on that. And then for several decades, when we were in training, we were using a lot of these psychopharmacological interventions. Pharmacotherapy was the first choice. And also in parallel, there is the psychotherapy paradigm that we were using a combination of pharmacotherapy, which was really targeting the neurotransmitters and the receptors in the brain, and we were using these psychodynamic psychotherapy, CBT, supportive counseling, combination techniques. But, we are still at the phase that we are thinking, oh boy, this is not making a difference yet. There are so many treatment resistant cases. So for the past decades, there has been a lot of research done, and we are looking at the abnormal circuitry in the brain. We are thinking now that the neuronal connections need to be stimulated. There should be another mechanism of action to address these treatment resistant cases are the psychiatric disorders. That led to the discovery of the neurostimulation technologies that has been in use for some time now. What are those device-based interventions? Those are the, first one is the ECT, which has been there for a long time, and repetitive transcranial magnetic stimulation. I'll be spending a lot of time on discussing about the RTMS, and there is another device-based deep brain stimulation. I'll get into more details as I discuss the modalities. And why did we need to think about that is that, depression is really a lifelong, chronic, debilitating illness that can cause, it is costly with the healthcare expenditure as well as the time lost at work or the employment. We spend a lot of time and energy into bringing them back to the workforce. Sometimes the treatment resistant cases are the ones that we struggle with. And we also found, just like I explained, that there are limitations to the conventional pharmacotherapy and psychotherapy, and we are seeing more and more treatment resistant cases, especially post pandemic. And we are forced to think out of the box and think about other strategies to address these conditions in a safe and effective manner. And of course, they need to be evidence based. Whatever we do in our field, we need to look at the clinical studies and look at the data, and if it is FDA approved or cleared, for example, for devices. And what is the timeline? Like when we start thinking about the interventional psychiatry, it started way back in 1930s. Actually, it started in 1929 when they invented the cardiac catheterization for the first time in medicine. 1938 is the landmark. That was the first time ECT, electroconvulsive therapy, was utilized by a physician in Rome. Actually, the first case was an individual who had severe case of mania with the delusional. It was not for depression. He was roaming the streets of Rome, and actually 10 treatments were used, and he was able to get back to his job and able to return home from being homeless. Since then, there has been lot of research done with the ECT, and they have really made some remarkable modifications to the techniques that they used. And still to this date, ECT is the effective treatment for depression. And in 2000, since then, the ECT had gone through some changes. 2005, there were other FDA approvals for VNS, DB, deep brain stimulation. But in 2008, for the first time, FDA cleared the first transmagnetic stimulation therapy. It's a local company, Neuronetics, Neurostar. Since then, there have been multiple devices, and there are applications expanded to anxious depression, obsessive compulsive disorders, smoking cessation, and neuropathic pain. And then another breaking discovery and the approval that came through in 2019 was the Spravato, which is for the treatment resistant depression, mainly with associated suicidality. And Spravato is nothing but an enantiomer of the ketamine. Ketamine is an anesthetic that was used widely prior to that, and it was FDA approved in 1970. So it acts through a different mechanism in the brain, the NMDA receptors, which are excitatory. It's the ketamine is the inhibitor of the antagonist of the NMDA receptor. So when we say treatment resistant depression, what is it? What is the criteria to qualify as someone having treatment resistant depression? An individual with major depressive disorder who failed at least 2 antidepressant treatments with adequate doses. That means it got to the therapeutic dose and for an adequate duration, which is 6 to 12 weeks in our literature in the current episode. And they have not responded to the treatment, and they are considered to be treatment resistant depression. When we were looking at some of the insurance policies, they also want to know to approve for TMS or any other modality, whether they have received trials of psychotherapy as well. So that's one of the things that we need to keep in mind. But most of the insurance companies ask for how many trials of antidepressant medications were done previously. And what are in interventional psychiatry, what are the modalities? First one is the electroconvulsive therapy, deep brain stimulation, vagus nerve stimulation, Spravato, esketamine, and transcranial magnetic stimulation. And let's discuss a little bit about the ECT because that's the foundation, and we are still using ECT. It's a non-invasive procedure, but it's an electric stimulation to the brain to induce a controlled therapeutic generalized seizure. And it is the most effective treatment for depression. And one another indication that we use ECT is for catatonia. And it is still widely used, and there have been several changes made to the technique from 1938 to in between to 1950 and into 1960s. They have made changes to the anesthetic that they use and also tried to figure out the stimulus that they were giving to the bilateral, to the unilateral. And as the memory deficit or the cognitive decline seems to be one of the concerns with the ECT, they really made to work it to get it to the ultra wave form, which is like a brief stimulus, and also unilateral. And there, I have had cases that who were receiving ECT, and we do have one at Woods who is currently receiving the maintenance treatments. One of the drawbacks are the, roadblocks with the ECT is, it has to be under general anesthesia, has to be done in a specialized kind of like a monitored setting with an anesthesiologist present. And also, after the initial phase of treatment, you have to have maintenance treatment because the relapse rate is pretty high. And a lot of times during the maintenance treatment, the individuals who are, really got the benefit, they fell off. Continuation is going to be a concern, but it is the highly effective treatment. And the memory side effects are huge, and they can be minimized by such as unilateral and ultra brief pulse stimulus. Next one is the deep brain stimulation. It is widely used for Parkinson's disease, and if there is a tremor, and also for obsessive compulsive disorder. And it is an invasive procedure. You're putting a device or a implant in the brain, particular part of the brain, for example, Parkinsonism, that where it goes. And there is a pulse generator connected to a pulse generator, and the improvement takes weeks to months, and it's invasive. And there are other, concerns and side effects because you have to go into the brain. But it is reversible. It's if they do not feel it is effective, they can go in and take the device out. But it's another surgical procedure. Those are the surgical side effects, and because they are putting it in the brain, infection rate and the hemorrhage or other complications from the procedure. And the other one is the vagus nerve stimulation. It is FDA approved for treatment-resistant depression as well as epilepsy. Initially, they were using it for intractable epilepsy, but the treatment-resistant depression indication came in 2005. And it is again another device implanted onto the right vagus nerve in the neck. And there is another monitor that's hooked to the chest, and you need to send the pulse to stimulate the area of the brain. And it has, it is not, it is expensive and limited insurance coverage. I think for depression, they go in and out. But on the other hand, for intractable epilepsy, there have been more approvals, insurance coverage available. The common side effects are the hoarseness of the voice, and there is a change. Stridor can occur with the VNS. And Spravato, which we are actually looking at right now for our outpatient programs, is the esketamine. It's a nasal spray, And it is self-administered, but it needs to be administered in a medically monitored outpatient setting. It's been FDA approved for treatment-resistant depression, major depressive disorder with suicidality. It's very rapid and effective. And people who did not respond to the oral antidepressants, it has shown to be very effective. So in an acute crisis or acute suicidal kind of situation, when you are dealing with that, this could be an option. And each device has two sprays, one in each nostril. It's the total dose is 28 milligrams, and there are indicators on it. One spray after one spray, it gives you the green signal goes, and then you spray the other nostril with the other one. One of the things is that after the administration, they need to be monitored in our setting for at least 2 hours. Yeah, 2 hours, because there is a concern for respiratory depression. And they may also have symptoms of dissociation. So they need to have a driver with them who can drive them back and forth. Dizziness, sleepiness, and spinning sensation are one of the side effects for Spravato. It's twice a week administration for 4 weeks, and we supplement or complement with psychotherapy as well. And they could be on the long-term antidepressant medication at the same time. They do not need to stop the antidepressant or the psychotherapy. And the main contraindications are bleeding in the brain, or if there has any history of head injury with bleeding in the brain, or any history of aneurysm in the brain, we do not administer Spravato. Another one is arteriovenous malformation. Because of the risk of abuse and psychological and physiological dependence, it's been monitored through the REMS protocol, risk evaluation and mitigation strategy, that the provider has to enroll, as well as the outpatient program, and also the pharmacy also needs to be certified. We have done this synergy, and we are in the process of doing it for our Center for Behavioral Health. And coming to the topic of discussion is the transcranial magnetic stimulation. This is FDA approved originally in the beginning for major depression, later on for obsessive compulsive disorder. The procedure itself it's non-invasive. It's a repeated application of the magnetic pulses to the brain. It is safe, and it's an outpatient procedure, and they do not need any anesthesia. It's associated with very few side effects. The most common thing they complain about is the scalp discomfort, where we are using the coil. And what it does basically is we are sending the rapid magnetic pulses and to the particular part of the brain, and they induce the electrical activity. And we use it in people, again, each insurance company has a different protocol, but most of the times it's failure of the two antidepressant medications. And the modality itself is the repetitive. The magnetic stimulus here is you are sending like that. It's not banging on the head or anything. It's the stimulus going into the brain. It's a focal application on the cerebral cortex. We target the cortical area of the brain, and small electrical currents are generated, and they stimulate that particular part of the brain with the nerve cells. And what we think is the circuitry is changing. And from the magnetic field can pass through the skull to the brain, and it does not involve seizure induction. That is the major difference between the ECTs. It is general anesthesia, and it's an electrical stimulus. This is a magnetic impulse to the brain, and they are completely alert during the procedure, and you do not need anesthesia for this transmagnetic stimulation. Some technicality here, don't worry if it's too much, is that most of the providers need to understand. We first do the motor threshold determination. That is, what it is really looking at what pulse is really needed for a person to have some level of activity. And we see that from the contralateral limb, that's the upper limb, the hand, in the thumb movement. So it could be anywhere from 40 to 60 in normal individuals. And we figure out from that part that what is the pulse intensity, that magnetic field strength that we can use for treatment protocol. And how do you determine where you are going to be using the coil, or the placement is the technicality in this part with the RTMS. I think, people to kind of like, get worried that am I using it on the right place? That's more for the providers to figure out, and there are different techniques, and they have done a lot of research into it, and it's a modified one protocol is the 6 centimeter rule. And you put a cap on and you measure the area, and from the ear here to here, and then where it crosses 6 centimeters. Later on, they found out that, oh, maybe that's not so effective. And they came up with much more clear cut with the EEG monitoring system. Most of the companies provide those caps with the lines on it, and then you calculate for each individual and you save the cap for the next one. And the number 3 is the neuronavigation technique that we are actually looking at it right now, is a computer-based model. You put in the numbers, you calculate, and the computer tells you where to place the coil. So there are like a lot of improvements and enhancements done within the TMS system itself to make it easier for the provider to do. And we focus mainly on the left side of the brain, on the left dorsolateral prefrontal cortex. That's where it goes. And in certain cases, the right brain, I'll get into the more details. But when you are prescribing or coming up with a protocol, there are different things that we need to keep in mind, which is the stimulation site I just mentioned, left side of the brain, and how frequently are you going to use. There are different protocols. So stimulation frequency and what intensity you are going to use. And the intensity comes up from the motor threshold that we calculated, the thumb movement. It's 100 to 120% of that level. So 40 is the motor threshold. You may do 50 or 60, and you can change that parameter. And how frequently are you going to be using these treatment sessions? And also there is a variability, and there is a set protocol for TMS. But again, depending upon the individual, you can change the number of stimulations or the pulses applied for session, and the total number of pulses that you are going to use per session. And a lot of times all this information has to be coming up like a treatment recommendation after we determine the motor threshold. And that's what we apply for prior authorization to the insurance company. So this part is what it seems like the complicated technicality part of it. Can the prescribers, for example, the psychiatric nurse practitioners or the psychiatrists like Dr. Hawk or myself, we go through the training. I have done 2 trainings already with 2 certifications. And we can also retrain other people. But there are Duke University, Harvard, as well as the Clinical TMS Society offer the certification programs. So that prescription has to be coming from a psychiatrist or a trained provider who has the certification from a valid from a university or the society that gives this accreditation to use the TMS stimulation procedure. So the protocols, just like I mentioned before, there are two of them. One is the left dorsolateral prefrontal cortex. We think in the brain that the left side, most of them are right-handed, but on the other hand, if there is an issue with the left side, and we can use that on the right side of the brain. I'll get into more details when we discuss the other machines. It's proven to be effective, and that is the FDA approval for left dorsolateral prefrontal cortex is the 30 independent clinical trials, included multiple sites. And the first FDA approval was based upon that left dorsolateral prefrontal cortex, and they used 120% of the patient's resting motor threshold. If you think of the motor threshold as 40, they were using 120%. And the approval was for 3,000 pulses for each session. How they administer is that pulse, each pulse is 10 pulses per second, and you do that for 4-second train. So you are doing 40 pulses in one train, and then you give a brief pause for 26 seconds, and you repeat those for 37.5 minutes. That's the 3,000 pulses. And you can feed into the machine whatever you use, whatever system we are going to be using, that you can pre-formulate all that, and then it just does it automatically. And the low frequency one, that is the high frequency protocol. And the low frequency one is for the right dorsolateral prefrontal cortex. And they have shown therapeutic equivalence is the same. There is no problem, but unless there is a certain indication that there is a complication with that part of the brain, we go to the other side. And it's a little bit shorter than and it's a low frequency stimulation compared to the left side. And coming to the, what are the major contraindications is one big thing is the metal in the brain, in the head or neck areas, any kind of magnetic or any magnetic sensitive metal, because we are sending the magnetic pulse there, and that can create some heat. And also there could be thermal kind of injury to the adjacent tissues in the brain where that object is. So that's an absolute contraindication, and we get detailed history on that part prior to using any kind of TMS stimulation. And we need to ask detailed history about any metal plates, clips, electrodes, any kind of pumps, any stimulators, cochlear implants, pacemakers, any fragments, tattoos with any kind of metal in them close to the head, and any kind of possible other sources of metal. So that's an absolute contraindication. And there are another modality. What so far I have been describing is the repetitive transmagnetic stimulation. Another one is the deep RTMS, repetitive transmagnetic stimulation. That is a different kind of coil that's called H coil. And there is only one company that does that. That's the Brainsway. And it is applied deep TMS is high frequency to the left side, but it's the coil goes on the top of the head. I think you can see it here in the picture. It covers the whole head, so it goes much deeper, and the magnetic field is a little bit less focused than the figure eight coil. The other one is the figure eight coil. This is the H coil that we call. These are the different types of Brainsway H coils that are FDA cleared. And they have 3 indications so far. The first one is for depression and anxious depression. Recently, they got it for the geriatric population as well. That is H1 coil for the depression and anxious depression. H7 coil is for OCD. And for smoking cessation, it's a different coil, H4 coil. And the other figure 8 coils that are approved are cleared by the FDA are one is MagVenture, Neurostar. Neurostar was the first company that got the FDA clearance for depression. And MagVenture has 3 indications as well: depression, OCD, and neuropathic pain. And Nextim, same thing. They have depression and depression. Cloud TMS and Apollo are two different companies with the same indications. They all have the figure 8 coil. So that is the, when we are trying to set up our practice, we need to think about which coil we are looking at, figure 8 or H coil. H coil is the one with the brains where there is only one company with that. And how do we set up the practice? What do we need to do? First, our psychiatrist and the psych NPs need to go through the certification and the training process. And operationally, we need to look at a space in our outpatient service, look at, identify one office that's a standard. They give you the dimensions 12 by 15. It should be noise proof, individual treatment rooms. You cannot put 2 people in one. And there should be a TMS space for TMS machine and a chair for patient and space for a desk and a computer for the provider. And there should be sound barriers and neutral kind of soothing decor. And because the machine can make the pulses make a little bit kind of like a buzzing noise, we recommend them putting on the earplugs. And those are earplugs, not AirPods. AirPods has metal in them. So we need to provide the earplugs. And the personnel and training, as I mentioned, they need to go through the certification process. And the recommendation, most of the insurance companies would like the psychiatrist to be prescribing the treatment. And a person, CRNP, the provider needs to be accessible while the treatments are going on. They don't need to be present in the room for each and every treatment, but they need to be accessible. Some require in person, not virtual, because there is one complication. It can induce seizure in some. I'll get into more details. And the Clinical TMS Society recommends that a TMS, we can train a technician to administer the stimulation. And most of the practices all over the country, they use a TMS technician. It's not administered by the provider. The TMS technician has to go through special training. And by the way, most of the manufacturers also provide their training, and all the office personnel have to go through the training to be certified by them as well. The TMS technician should have the training on how to map the motor cortex. When I was mentioning about the cap, putting the cap on, the measurements, and where to put the first the coil to identify the motor threshold, and also understand the parameters, when the doctor is prescribing the treatment recommendation, this many pulses per second, this is the frequency, and this is the each train, and this is the gap in between the train. They need to understand all those, and also need to be able to do a seizure. If there were to be a seizure, the protocol should be in place to manage them, and they should be available at all times and present in the room. One-to-one observation during the treatment is done because of the possible seizure activity. And they also recommend that each session or each treatment prior to that, the technician need to ask questions about any changes in the medications. Did they sleep well last night? Did they do anything different? Did they have any drinks, alcohol last night? Because they all reduce the seizure threshold. And some of the practitioners actually, if they did not sleep well, they send them back home. And also need to monitor if they're comfortable, if they have any other things that are going on, or if the neurologist changed any of the medications, or if there is anything that can happen that can lower the seizure threshold. And to set up the practice, each practice needs to develop those kind of training, and we need to have those standards operation practices in place, SOPs in place. And the other thing with the implementation of the TMS in our practice, we need to establish a measurement-based care to show the outcomes. And also, the insurance companies, we need to justify the continued or the pre-authorization for maintenance treatments, and also the continued treatments, the number of sessions per each episode, and also if there is a relapse to do the treatments again, you need to justify. So there should be a measurement-based approach to this practice. And there are multiple screeners. I know we use PHQ-9. HAM-D is the one that got the approval for the from the FDA for the TMS. Neurostar, when they did the clinical trial, they utilized HAM-D. What are the things when we say like non-responsive, partial response, remission? On any of the scale that we use, if it is less than 25% decrease in severity, that's non-responsiveness. Partial response is 25 to 49% decrease. For example, if we are using PHQ-9, that's the if it is greater reduction than 50%, that's a response. Remission is complete absence of symptoms. And just a brief idea of what are the scales that we use. You guys are all familiar with PHQ-9. It's easy to use and it's built into our EHR. And the other one that we use is the HAM-D. It is just like I mentioned, this is the one that they use to get the approvals from FDA. I'm not going to go into too many details. Montgomery-Asberg Depression Scale is another one that's widely used. It is easy and quick to implement, but there are interpretation is difficult, and there are certain items missing to really monitor the depression in that category. And there is QIDS-16 is another scale that some practices, actually I was pleasantly surprised when I went to the Clinical TMS Society certification this year, is that a lot of people are using QIDS-16, and one of the practitioners did mention that it was built into their InSync. And what are the codes we use for billing? The one that widely used are the first one is the 90867. Most of the insurance companies approve one 90867 for treatment period. And if there is a relapse and if we need to go back, there is a lot of justification we need to do, but that includes the initial assessment as well as the cortical mapping, that's the cap you put on, and then determination of the motor threshold, and the prescription needs to be generated. Then we submit to the insurance company from that point, and then get the approval for number of sessions. So that needs to happen, and that's the code for 90867. 90868 is like the follow-up sessions. And if there is a change, most of the companies approve 90869. For example, they went out and they partied and they had a few drinks and they came in the morning and told our, tech that, oh, by the way, I had, a couple of drinks. We need to determine the motor threshold again, because to avoid the seizure risk. And that redetermination and the management includes 90869. But it is sometimes a common practice for people to say, go home and come back again, because we don't want to take that risk. If they had a party last night and they were, you don't want to take the risk of inducing a seizure. And again, the development of the policies and operating procedures are the keys, and we need to have a system in place. And these are the things, as the outpatient program directors, we need to make sure that all these things are in place before we start the practice. We need to define what's TMS, who is administering it, who is certified to do that, and whom are we going to serve, and what are the diagnoses and the codes we are going to use, the consent process, and how do we manage clinical management strategies. We need to put all this in place, and also we need to develop template for the notes, rating scales, which one we are going to use, PHQ-9 or HAM-D. And the patient education materials have to go in there, and what sort of training we are providing to the tech, and do we need a nurse or a MA in place, and how are we going to be credentialing, who is keeping track of those research, and how are we going to do the evaluation process? Because to get the insurance authorization, there are specific things that need to go in there, especially about their prior psychiatric history, what were the treatments, antidepressant trials, and the symptom criteria to qualify for treatment-resistant depression or OCD. I'm focusing a lot on the depression, but for OCD, you need to do the YBAC and and the symptom intensity, severity, and the score, and over the time frame, what kind of medications are did they go for the psychotherapy, how effective, all those things need to go into the chart. So there should be a system in place. And from the medical standpoint, how do we manage seizures if they were to happen, which is very rare? And if they have some concern with the stimulation, are they able to tolerate, or do they have a headache? What should we be doing? How do we change the protocol and the frequency of the sessions? And documentation is important, and checks and balances for those things should be in place. And we need to keep a binder for the patients about information about the TMS, and what are the risks and benefits of the treatment, and all the consents, educational materials, and what are their expectations, what are they expecting from the treatment, and the course of the treatment, how many days of the week they need to come in. Most of the authorizations are for 5 days a week for the whole month. So this is a commitment from the patient that's coming in for the treatment. There are some accelerated approvals that are recently FDA cleared, but most of the manufacturing companies have the system in place. There are, like, I'm not going to get into too much technicality, but there are theta burst and accelerated theta burst, and they may stay for 2-3 hours, and then we do repeated sessions. Certain insurance companies are going through the approval process right now, but all those things should be included in our manuals and the binders for TMS. And people talk about seizure risk with TMS. The incidence is really, really low. And because of the primary motor area where we are stimulating, that's the part that's, we are of the concern. But the motor threshold determination and using appropriate stimulus makes all the difference. And the other thing is that all seizures are self-limited so far. Nobody in the clinical studies, no one suffered lasting physical sequelae from this TMS. And the steps that we need to put in place to evaluate a person for the seizure risk is that we need to have a history and physical, or a copy of the history and physical. If there is a seizure history, we need to know that beforehand, and we need to get a detailed medical history. And there is a questionnaire that during the initial clinical assessment, we need to complete. That is the TASS. I'll get into the detail in the next slide. And also, we need to find out about, just like I mentioned several times before, we need to find out how their day was yesterday, last night. Did you sleep good? Any medication changes? Did you use any drugs or alcohol? And we need to set those parameters before we do the stimulation or the treatment for that individual. This is the TMS adult safety screen that needs to happen each time we do the stimulation. It should be done on the clinical assessment time, the first evaluation, and we need to quickly check on if anything changed for each treatment session. Not so much about the, did you have a stroke or anything changed, or did you have, but quick things about like anything changed. Did you have more or less about anything medical going on since the last time I saw you to now? But this should be there on the front of the chart. So the summary part is that most of the manufacturing companies that we use 36 sessions within 90 days. That's the approval. And it's most of them are FDA cleared devices. It should be cleared, not approved. There, it's a typo. And it should be prescribed by a physician for the most part, but can be delivered by a TMS technician. Physician or the psych NP should be available. And there are medical necessity criteria established for treatment in, most of the states has the similar criteria, a diagnosis of major depressive disorder. And it should be on the PHQ-9 scale, it should be severe, and it's 18 years or older. And some have 4 or more failed antidepressants from 2 different classes, but it could be, there are some of them, they come like Zoloft, Prozac, they go on a list. We need to get a detailed list from them. And psychotherapy, failed psychotherapy trial. And the exclusionary criteria are metallic implants. And if there is a history of seizure, it's not an absolute contraindication, but on it, we need to make sure that they have been seizure free for quite some time and they have been stable. So if we were going to be using TMS on somebody who has a seizure history, we need to make sure they're not actively seizing right now. And we need to find out if there is any change in their seizure medication each visit. And the task should be completed on the clinical assessment side, and we need to find out what the changes in each visit. Each one, has their own. So when we are looking at credentialing with insurance companies, we need to find out what their protocols, and we need to put those prior authorizations in our system. So altogether, on conclusion, it's a technology-based approach, but it is well tolerated and effective. And there are considerations, practical considerations that we need to really think it through. It's cost wise, the most of the manufacturing companies, they may lease, or we can purchase the device, but it's costly, and the insurance coverage could be an issue. So there is a lot of legwork that needs to be done. But this is one of the effective treatments for treatment-resistant depression, as well as obsessive compulsive disorder. So there are some references here. I can send it to you guys. Let me stop sharing. And if you guys have any questions, I'm happy to answer, or we can discuss further. Just to give you guys an idea of what we are looking at our outpatient center at Woods Services, we are looking at two manufacturing companies right now. Between them, we'll be making a decision. One is Brainsway with the H1 coil, H coil, and the other one, Figure 8 coil with the MagVenture. So those are the two companies we kind of did the due diligence, and we will be looking at and gradually roll out to other affiliates within Wood System of Care. And MagVenture has one of the advantages. I know I see Dr. O. One of the advantages is that it also has an indication for neuropathic pain. And it doesn't neuropathic pain neuropathic pain, you can use it anywhere on the individual's body. For example, if it is in the lower limb or the extremities, you can use it on there. It's a different kind of like coil that comes, you can just put it on. So that's compared to the smoking cessation, we felt maybe, MagVenture with the neuropathic pain indication would be much more useful, not just for our population, but anywhere. There is definitely that use. I don't know for smoking cessation if people would really want to go for TMS, like going under, stimulus. So that's, Dr. Mills just asked a question about how we decide which coil that we'll be looking at, or what's the decision-making point with that coil. So the H coil goes on your scalp. It's a little bit kind of like a helmet kind of thing. You strap it in. From the technicality part of it, it is a little bit, it goes deeper. And the other thing is it's wider stimulus part of it. It's not, really specific to particular part of the brain. One of the things people say, I don't have the data. I did ask the Brainsway people to send me the data on this, that the clinical TMS society, some of the faculty members did mention that because it's deeper, seizure risk may be higher. So that's one of the things I'm looking at right now, is that how much is it different? And then again, another decision-making point is that smoking cessation versus, neuropathic pain. Which one should we take? And the another thing, another decision-making point with the MagVenture favoring is the neuronavigation system. It's a computer-based kind of like approach to determine where the coil should go. So, it's not like we need to train the technicians, but on the other hand, you can quickly do it. It's computer model, you can put in the system. There is expense attached to it, but if we have enough volume, once we build it in, there is an option to go with neuronavigation. People who have been using neuronavigation, they love it because it's computer based and it stores it. And the next time the client comes in, you put in the name and it syncs into the EHR quickly. So, the treatment protocol and the prior authorizations apparently from neuronavigation system to the EHR and to the prior authorization, it's easier. So one click goes into the system. Hopefully that does, I want to believe it. So that's one of the advantages of the MagVenture. Our business team has not met with the MagVenture yet. Janeta is in the process of setting that up. So I'll keep you all in the loop. And then I think Tom asked, is there research on how ECT works on individuals with TBI? I'm wondering if there are pros and cons to treating that population. That's a very good question. You are inducing the seizure there, Tom. So, you would think that, but on the other hand, cognitive or the memory, deficits are a major kind of like drawback with the ECT. I can look up for any literature on it, but I have not. It's mainly indicated for only treatment, depression, major depressive disorder, and catatonia. And 1 minute quick thing, I myself, I have had few clients whom we did maintenance treatment. Like I said, we have one in Woods Community Services who is currently getting the maintenance ECT. I had to recommend for someone, and I went through the process. She's a young lady, one of my most challenging, challenging ones are your favorites too. Presented with, from Kennedy Krieger, step down, presented with significant OCD, which was interfering with her day to day. She could not function. She was literally wearing like rags, like ripped clothing in certain way. That was the intensity. The another issue was the extreme social anxiety. She could not tolerate anyone in her personal space. Upon consultation with Dr. Wachtel at Kennedy Krieger, we sent her to Mount Sinai for ECT. That was an off-label use at that point for ECT for OCD and social anxiety. Remarkable improvement. I could not believe myself that she was giving hugs to people and she was wearing regular clothes. Where we fell apart is that after that initial treatment phase, we could not maintain maintenance because she slipped through. Her anxiety returned and transporting her back and forth, and just even her compliance in the anesthesia room or getting her onto the table, everything was really difficult, even administering general anesthesia. So maintenance phase is the part that's extremely difficult. You need to have like really supports in place. And, to do the treatment phase again was not applicable. But yeah, both of these manufacturing companies for TMS are interested in us doing some sort of study for individuals with autism with extreme rigidity. So that's, something in the works for both companies. So, more to come on that part, because sometimes we can look at the rigidity as the OCD trait in some of those individuals. I know on Woods we do have on the adult population. We are struggling with few there. Any other questions? Good. Thank you. Thank you for all your attention. Feel free to let me know later, and whoever wants to be involved in the discussions with and making decisions about our next steps when we are getting our, deciding on which one, or if you are interested in being actively involved, in opening up, either one, Spravato or TMS, just let us know. Thank you. Bye.